Heard at Health is sponsored video content brought to you by MedCity News.
I'm with Asima Ahmed, co-founder and Chief Medical Officer of Fertility, which is a family care platform serving employers and health plans. So Asima, women's reproductive health, starting from preconception all the way through to menopause, is a continuum. But what we're seeing in the marketplace is that their services are being catered not in a holistic way, but in a fragmented fashion. Why is it important to address it holistically?
Well, the thing is, what we're seeing is that women's healthcare, men's healthcare, when it comes to reproductive health, is treated in these isolated events. So for women, example, it might be contraceptive care, infertility or fertility, pregnancy, postpartum, and menopause. And yes, they are separate events in our life in a way, but they're all interconnected, because what I think of is they're all a part of the lifetime continuum of lifelong hormonal health, because hormones affect us from before birth until our last breath. And so what happens is people get this fragmented experience. They have inequalities in the type of care that they might be getting, like the quality of care. They are also bouncing sometimes from in-person provider to provider to provider, or even with digital solutions, from solution to solution to solution. Sometimes they get lost in the mix. Sometimes information is dropped along the way because there's no formal handoffs like there is in a healthcare system, for instance, in some cases. And so they end up with this very fragmented experience where, again, the quality is compromised. Things can be dropped and lost along the way, and they can end up with suboptimal outcomes in the process.
That makes sense. Why do you think people still default to IVF as their first fertility care option? And what other effective options are being overlooked?
Well, the thing is, when people think about fertility care, traditionally we just think IVF automatically. And so sometimes people just don't know. And that's actually the sad part about it, is that sometimes people delay coming into the clinic because they think the doctor's automatically going to tell them IVF. Now, don't get me wrong, being a clinician and being in this field, I can tell you that in some cases, there are situations of misaligned incentives where somebody might be encouraged or pushed to go into the IVF route because for some people that makes more money, right? Whether it be in a clinical setting or it be even completely similar to us, sometimes people make more money when people do IVF. Right. But there are many things that you can do along the way, and that's where I think Carrot really shines, because we are able to talk to people about all the things that they can do before they need to do IVF. And again, don't get me wrong, some people need to do it. If they have blocked tubes, poor sperm, certain diagnoses, IVF is the only way to grow your family in those cases when you're using your sperm and eggs. So our members can work on their nutrition, their lifestyle habits. Like we launched Sprints this year, which focuses on metabolic health and fertility.
That's right.
So improve their nutrition, work on their movement and exercise, work on good quality sleep, reduce stress, and then also learn about ovulation tracking, things like ovulation induction with oral medications and intrauterine insemination. All these things can be done even before you walk into that journey of IVF.
You mentioned metabolic health. So can you sort of connect the dots in terms of the role that metabolic health plays in fertility outcomes and how your company is addressing this?
Well, what we're seeing is that globally, the rates of obesity and some types of metabolic disorders like diabetes are increasing. And just like metabolic health is a part of your overall health, it's the same thing with fertility. Metabolic health and your overall health affect your fertility. And so people who might have obesity or poorly controlled diabetes, that can result in them having subfertility and infertility. So what we do, again, is we focus on those types of things that they can target in the months leading up to pregnancy, right? We call it our premester, or basically preconception period. So 3 to 12 months leading up to pregnancy, try to optimize their health to help them get pregnant faster with fewer interventions and also have a healthier pregnancy. So a good example is someone who has PCOS, a woman who has PCOS, obesity, and perhaps also diabetes. She, because of that, is not ovulating regularly. Helping her go through a program like this, which is the first of its kind, and lose 5 to 10% of her body weight can actually help her ovulate more regularly.
I see.
And then she might not even need to do ovulation induction or something like intrauterine insemination or IVF. She could probably just ovulate on her own and get pregnant with time intercourse. Now, related to that is that once she does get pregnant, because of those changes, because of that weight reduction, because of the optimization of her diabetes, now she's going to have a healthier pregnancy, lower risk for birth defects, miscarriage, C-section, preterm delivery, and with those preterm deliveries also decrease risk of neonatal ICU stay for the baby.
Now, you work with multinational employers in terms of providing fertility benefits. How does it change? What's the challenge in providing these benefits across different countries and cultures?
Well, one thing that we're seeing even in the US is depending on where you live,
True.
the local laws, rules, and regulations might be different for you than somebody, 3 states away, right?
That's right.
And so that's the thing is like, we're seeing that just in the US, but that exists globally around the world. So there's the different laws, regulations, and policies that will affect what types of care they can access, but there's also culture and religion and what types of care they might find to be acceptable.
Mm-hmm.
So the thing is, when we started the company, we wanted to be global from day one. So we've been hyper focused on these things, and we have a deep understanding on a global level of how care can be provided.
Mm-hmm.
And in those cases where care cannot be provided or might not be found acceptable, and someone wants to seek care, like cross-border care, we can help them through that journey as well. We've had lots of patients or lots of members go through this, and we've been able to help them build their families in this way, which has been great.